So welcome to the U Arizona Health Sciences Tech Talk Tuesdays. Tech Talk Tuesdays is a series of bi-weekly conversations all about engaging thought leaders, experts, researchers, and healthcare professionals in conversations around the advancement of technology and health sciences. We're happy to have Dr. Theresa Cullen, who's the director of the Pima County Health Department, joining us today to discuss health disparities in Pima County and how technology can help us bridge some of those gaps. We're going to open up for questions at the end. If you'd like to submit questions via chat at any time throughout the presentation, I will read those out at the end as well. And with that, I will turn the time over to Dr. Cullen.
Okay, and hopefully you can see my screen.
Yes, it looks great.
Yay, God, when technology works, it is amazing. Okay, so thank you for welcoming me. I'm sorry I'm a little late. I couldn't find the Zoom link. So let me tell you a little bit about me, and then we'll go quickly through some slides, and perhaps we can have a discussion, which would be much more fun, I think, than a PowerPoint. And I will make these slides, I'll share them with Caitlin so you can have them, because some of them are a little dense. So I'm Terry. I'm a physician. I spent 25 years as an active duty public health service officer, working primarily in Indian country. I ended up being a chief information officer for Indian Health Service. I spent a year working at Health and Human Services, reporting to the deputy secretary and the CIO, and working for Todd Park, who went on to be the chief technology officer under the Obama administration. Then I spent almost 5 years as the chief medical information officer for the VA based in DC. And then I spent the last 4.5 years before my current job working in health system strengthening and informatics in low and middle income countries. So I've kind of had this long hegira, done lots of different work, all of it really focused on health justice. And the real question is, how did I get into technology? Because I never envisioned I would be a technologist. And it harkens back to actually an incident in 1986 when I was working at the San Carlos Apache Reservation. And I saw a lot of patients, like 82 in one day. And I thought, this is crazy. There has to be a better way for me to provide care. So I got into technology. So with that, we're going to go through some slides to show you how to use technology to improve global health. I end this presentation with more questions than I start with, than I have answers to. So hopefully you'll be able to help me go through this. But I want to preface this by saying, I don't believe technology is the solution to anything. I think it's a cofactor in trying to help achieve equity and justice. And I'm going to show you a few things we've been doing with technology at Pima County, but really I hope I leave you more with the understanding that this is really a comprehensive approach to how to address health inequity and how to achieve health justice. So we're going to talk about the role of informatics, technology, what's happening at Pima County, what isn't happening in Pima County, what should be happening in Pima County, and where we're anticipating being able to go. I want to remind you, my hope is that many of you are using human-centered design principles, user-centered design. You can do whatever you want, but there's really this acknowledgement of people, process, and technology for what we do, and that everything we do in technology should really be predicated on the establishment of principles. Actually, as part of the COVID work, we've been working closely with the public school districts as well as the private and the charters, and we started that work by really looking at what were the principles of the work we wanted to do. And so I think technology really needs to be bounded in principles. You see a few here. Those are really ones that are very common with human-centered design. I will say in the past, probably 15 to 20 years, all my work has used what we now call user-centered design. It was a pretty nascent field back in the 90s. Indian Health Service engaged with a group called Human Factors International, actually out of San Francisco in 2002. So for 20 years, people have been using human-centered design principles to make the best technological solutions. However, I would posit that many places still don't do this, or there's not a deep understanding of what it means to do human-centered design. The important thing from a public health perspective is really what the design thinking phases are, though. And you'll see in this human-centered design model, and obviously there's many, it's grounded in empathy. For those of you who are academic, and I actually come to this, even though my work was in low and middle income countries for the past 4.5 years, it was through a faculty appointment at Indiana University, working through a nonprofit there called Regenstrief. And the coin of the realm there, even though I was doing wonderful work, but it was grants and publications. The coin of the realm in public health, and I say this to people here, what's important to note, I've never worked at a local public health department before, but it's empathy. That the driver in public health and population health, in my experience, at least at this local level, is empathy. So the beauty of design thinking is that empathy is a really important part of what we do. And I think in many technological venues, you don't hear a lot of attention paid to empathy. It's actually the beauty of health and technology in that you can talk about empathy and compassion and have people understand what you're doing. I also want to remind people the principles for digital development. Hopefully most of you have seen these. They've been endorsed by people like the Gates Foundation. This started really from a user-centered design perspective for low and middle income countries. However, these are principles that have now been embraced by people like the US Digital Services and other vendors. And you can see, and I'm not going to spend a lot of time on these, but you'll see these principles teasing out through all the work that we're doing at Pima County and the work that we anticipate doing. The one thing I would call out here, given my experience of doing software development since 1986, so a pretty long time, I hate to admit it's been that long, is that designing for scale really matters. And many of you may be aware there's many technological solutions that work for a user population of 200, but as soon as you get to scale, they fail. Public and population health, it has a dependency on scale. We have to be able to scale to anticipate and help guide the decisions that will impact communities. So this designing for scale is really important, and I think it's fraught with difficulty. The most software programs and projects that I fail at that transition from going to a small N to a larger N of a couple thousand and or a million. So why do we care about technology and public health informatics? And I'm not going to once again read this for you, but you can see that public and population health is dependent upon technology. And if you think about an N over 5, you quickly understand why, right? That data, the ability to aggregate, to gather, aggregate, evaluate, and then do data for action depends on a large technological infrastructure. You are probably aware that public health informatics in this country is a neglected stepsister. It has not been well funded. It has always been an afterthought. The reason for that is the way the healthcare system is designed and the reimbursement models, and also decisions that the federal government made. And I can say this because I work with the Office of the National Coordinator for years, and public health informatics was always a secondary use of data. As we know, public health data is considered a secondary use of primary clinical data. I have never felt that way. I've always felt public health data is as critical, especially in the direct clinical delivery, as primary data for individual patients. But that is not a common theme. It's not, I would say, even integrated into the mainstream, despite the fact that we are in the midst of a pandemic. We actually have this amazing opportunity right now, I think, to show why public health matters and what public health informatics matter. So improving the quality of care is dependent on this, as you know. The other thing I really want to talk, however, is business process reengineering. So when we look at human-centered design, we look at people, process, and technology. Together, they really help formulate and really constrain business process. And business process reengineering is an essential component as we move forward to doing any technological innovation. So you can throw, and I've done this, you can throw any software you want. We used to call it throw it over the transom. Hopefully somebody's going to pick it up on the other side. Well, we know that without a business process change to a company, that throwing the software over the transom, there's not a significant change. in what happens in the outcomes. So this ability to have business processing really matters and needs to be paid attention to. So with that, I'm going to talk really briefly just about our Pima County non-COVID work that we've been doing. I say this publicly to my staff, so I can say it to you, we are not an exemplar of how to use technology. We are not a technology-driven local health department. However, we will be. And my goal is to make sure that we are the best technology-driven healthcare, local health department within the next 5 to 8 years. I would also caution you that none of this is quick. And once again, people may have quick solutions and they may come to you with what seem like amazing, amazing applications, especially if it's on a platform like Android. But transformation doesn't happen that quickly. It happens slowly. The ability to understand the people, the process, and the technologies that are required to make a difference require increased knowledge, increased experience, and really an in-depth understanding of your community and who you are working with. So what do we do well right now in Pima County from a disparity perspective? So this is a list, and I would remind you, I've only been here since May 1st. So I'm still in discovery mode a lot myself. But you can see we do have existing applications and hardware, just like every healthcare system does and every public health department has. However, it's inadequate. And we'll briefly go through some of that. We do have an electronic health record, and the reason why that is important is you'll recall, remember the N of 1, the only way you get the data from an N of 1 is being able to collect it most normally at the point of care, and then the ability to integrate that data into a larger data set. We do have media and web-based tools for community outreach and education. I would say they're not really what we would like to have. The example I will give you right now, because we are in a pandemic, is mask wearing. So obviously having media and web-based tools require you to understand what your population is, what health education can influence their behavior, how to track behavior, and how to track influence and or change that happens. You're probably aware that tracking mask wearing would be really a critical part of our healthcare model for pandemic control. However, there are very few applications out there to track mask wearing. Dr. Frieden, who used to be the head of the CDC, has recommended that that is one of the 15 metrics you look at when you're looking at your public health response. The way we track mask wearing is we look at complaints. So we kind of have a surrogate back of the door way into that data, but it's inadequate and insufficient. So those are just some examples of things that are community outreach and education that would be helpful for us to have a better insight into. We do use GIS a lot. I'm going to actually show you some GIS slides. They're not from work that Pima County has done, but they're from a vendor that we have been doing some work with later on in this presentation to show you how critical GIS data is. I'll give you an example. However, this morning or Monday, yesterday, I work closely with the University of Arizona, and I sometimes do their press conferences with President Robbins and Dr. Carmona, and this issue of the zip code 85719, which is a zip code around the university. It's a very large zip code, multiple census tracts, comes up because that's where we saw this spike that you may be familiar with, where we did a voluntary shelter in place. So we use our GIS data to do that census tract modeling. We do have other dashboards. I'm going to show you one later too. However, I could, with all accuracy, say on the press conference yesterday that 19 isn't lighting up. I know where the cases are, and I know they're not. There's some cases in 19, but right now Pima County looks more like a scattergram for COVID, and that's because of the GIS work we've been able to do. So our GIS is fairly progressive and robust, and we try to apply a lot of our lenses of equity and optics through a GIS lens, and we'll talk briefly about that because we use some other survey tools that we overlay on that. We do pay attention to integrated behavioral health. And then food safety. And the reason why I bring up food safety is if any of you have had norovirus, you may know why we bring up food safety. We want to make sure the food safety system stays okay. But food safety is, when I interviewed, just so as an aside, when I interviewed for my job, they asked me if I had any concerns. I said, yeah, I know nothing about food safety. So I've learned a whole lot. But it turns out food safety is really important, right? And it's really important from an equity perspective because you need to be able to identify where your problems are. So once again, this is where we see GIS and a large data set important. Early sentinel awareness, when I talk about the scattergram we're seeing in our census tracts, that gives us early sentinel awareness right now with COVID. And I'm going to show you some examples of the work we've done with COVID because I think it's important to show how technology has helped inform what's happening with COVID and what we haven't done. And then animal care, and you guys may be aware that Pima Animal Care Center is a national as well as an international model. And you may not think of technology when you think of animal care, but suffice it to say, there's a lot of software and other support that's going into the assessment of animal care, veterinary care, who gets what does it do to be microchipped, how do we make sure that animal is safe, how do we look at if we go to non-infectious disease epidemiology, what do we do with rabies control, how do we know what's going on in rabies in the community. And a lot of that comes from our ability to technologically follow trends. This is an example of COVID, but I'm bringing it up because I think it's more than COVID. So you can see, we talk about social determinants of health, and you see this here. I would also remind you there are social determinants of other things. There are social determinants of education. There's social determinants of work. There's social determinants of mobility. So it's just important to recognize that once you start to have a deeper understanding of social determinants, that they not only apply to health, they apply to wellness and justice. There are definitely social determinants of the justice system itself. The reason why I'm bringing this up is because I want to show you as we walk through technology with epidemiology, how we address many of these things. But these are all factors that theoretically have technology attached to them. And it is the integration of those data sets that in the long run make the impact of technology. That is not to say that it is not critical that each of these individually have the ability to address a problem. It's to posit, however, that is the integration of this data, technology, people process technology that makes a difference. And let me just do one example. You're probably familiar with COVID Watch at the university, and that enables you to determine whether you were a contact to somebody that has been a case. You're probably aware recently the CDC modified their definition of what it needed to be a contact. Before, it used to be 15 minutes in a row in 24 hours. Now it's 15 minutes throughout a day, throughout a 24-hour period. So you can have 5 minutes once, 5 minutes again, 5 minutes again. The beauty of COVID Watch is it puts that work together. It puts those 15 minutes together. The vast majority of us as individuals would be incapable of putting that together. At least I wouldn't remember. So what we know is that that's a critical part now, especially at the university, of how we can identify contacts. However, in and of itself, in my opinion, it's great. It's an important part of it, but it needs to be combined with all these other things that we see here. So I just want to show you this. I'm sure you've seen this slide. This is an epi slide specifically for SARS-CoV-2, which is COVID. And the reason why I'm showing this to you is I'm going to show you what we call an epi cascade and where we see technology working on the epi cascade and the impact you have. So when you design software, you really design end-to-end software in most cases, right? Like you may design a specific part of the software, but the reason why software and technology work is when you can do end-to-end data. And so what this will show you is how critical all these components matter, how critical they are, and how many of them really do not have sophisticated solutions. Years ago, so I've been talking about tech for a really long time. Years ago, I used to do this slide presentation beyond hemoglobin A1C. And you guys who are older may recall when hemoglobin A1C was this novel thing we did for diabetics. Now people would laugh if you said that. But there was a time when we never got beyond hemoglobin A1C, where all we said was, well, if we can measure hemoglobin A1C, oh my gosh, we've jumped over this huge hurdle. Now we're far beyond that in terms of diabetes and diabetic control and what we want to do. But it gives you an example of how you start and how you think about having to do data and technology development. So I have 2 slides on Epi Cascade. For those of you who are clinicians, you know you use a clinical cascade all the time in your decision making. I would posit to you that an Epi Cascade is just a little different. You still are doing a cascade. You're doing a cascade of thought. Now, for those of you familiar with software development, you know, we don't like to do cascade waterfall development anymore. Everybody does agile development. I think everybody has a different definition of what agile is. I would argue that still we do a lot of cascade waterfall development. But if you think about healthcare and you think about pandemics and you think about how you respond, you really are pushing from one to the next to the next. And that does not mean that in the middle of it, you don't do what I talked about for the cases of scattergram, but the vast majority of what our thinking is a cascade waterfall here. So let me talk briefly about the parts of this cascade, because I want to talk about it from a technological perspective and what we're doing well at the county and what we're not. And I'm using COVID as an exemplar. Obviously, you could use something else. It's hard these days to think a lot besides COVID, but trust me, we do other things besides COVID still at the health department. But a lot of our resources, both human and fiscal, are going into COVID. So prevention and identification, you remember, and let me go back really quickly, you'll remember these socioeconomic factors. So I'm sure you're familiar with the Social Vulnerability Index. So we are committed to equity, and we are committed to ensuring that we make decisions that help contribute to equity. They don't ensure equity, but they contribute to it. So if we believe that social vulnerability is a contributor to inequity, and I think most people would agree with that, then we have to pay attention to it. So the beauty is we don't have to develop a social vulnerability index. There is a social vulnerability index, and we're able to apply that to our data. We're able to identify known risk factors. Now, these risk factors can be for infection, they can be for morbidity, and they can be for mortality. And you know this, when you go and look at COVID-19 and you look at mortality, age is clearly a cofactor. Living in a long-term care center is a cofactor. So we use our information about long-term care, about assisted living, about what's happening in one versus what's happening in another to direct resources and to make sure that people are getting screened appropriately. So we use this analytics data to predict risk. You may be aware that the Veterans Health Administration just yesterday released an early predictive model for COVID-19. Now they have not, for morbidity and mortality, now they have not used it yet, but having spent 4 years as the CMIO at the VA and really working closely with their analytics and business intelligence group, they have a very, very large 20 to 30 million people database that they do a lot of their work on and a lot of querying. So I am sure that they have done a lot of quality control on this. Next, testing. Who, how, when, where, you know, should you test, should you not test? What are your risk factors? What makes you more likely to test? So appropriate testing is a huge question right now. There are some applications that are released right now that are mostly mobile applications to help people determine if they should test or not. But this is an area that is still very unclear because we don't have enough data. So we don't know who's at risk and who isn't at risk. But this is an area ripe for technology, ripe for a technological solution that I could download. I could put my data in, not in terms of was I exposed to a case, but let me just tell you about who I am, what my factors are, what I do in my daily life, what would be my probability. Remember, so much of medicine is probability. What would be my probability and when should I test? So we use this a lot with our contact tracing. When should you test as a contact? And to tell you the truth, I actually talked to some people at CDC. I said, why don't you guys just develop this as an application? I don't have a software shop here, so I can't do it. But these are the kind of things when you're thinking of technology and solution and entrepreneurship and innovation, those are what you find is the question that technology could help support and accelerate the answer to. And then reporting, you may be aware that standard terminology and standard messaging, very boring for the vast majority of people, like who really wants to talk about ICD-10, SNOMED, LOINC, CPT codes. I will tell you they are critical. I spent 6 months as the interim director of LOINC, whose home is at Reagan Street. I know more about LOINC and lab standards than I ever wanted to know in my life. But at the same time, what we know is that is what facilitates interoperability. And without interoperability, we cannot aggregate data. So it's really important that you pay attention to these kind of things that seem really immaterial and not important. Terminologists are not a dime a dozen. They are very critical components. And with COVID-19, you're probably aware because the FDA did so many emergency use authorizations, EUA of labs. What we need to do to evaluate that data is be able to say this PCR test is equivalent to this PCR test and not equivalent to this antigen test. That work is still to be done. I work closely with some people in North Carolina and Rhode Island, and we've been doing some evaluation of lab results related to COVID from a terminology perspective to see if there's any way we can get at that. And then passive and aggregate reporting. Then from an epi cascade, once again, for technology, it's really this care, case management platforms, this ability for shared responsibility. If I had to create one thing in my life, it would be to do this creation of this care case management platform. People have tried to do this for 30 years. I have tried to do this multiple times. I've had some successes, some failures. The whole issue of how do I do a care plan for an individual, let alone a community or a population, and make that work. I talked to somebody last week who I worked with 25 years ago, and he said something. I said, didn't we talk about that 25 years ago? He said, yeah, nobody's figured it out yet. So the beauty, I think the lesson for all of you is if you're interested in technology, there's still lots and lots of holy grails out there that we have not figured out for you to address. And then contact tracing, we talked a little bit about that. Metrics, I am really a data person. Shared development and multiple dashboards are really important. And I want to be sensitive to time because I want to take your questions. So I'm going to move on from here. This is a dashboard that we stood up. This is using our contact tracing case investigation data. At the bottom, you can see the segregation of the data by zip code, census tract, jurisdiction, school district. This is an example from District 1, who we work a whole lot with, but you can do it any way you want. Cases by gender, age group, death, and then you can drill down into any of these. This is available on our Pima County website. This looks so easy. I know it looks so easy. It really took months to do this. This is the kind of data that the public expects, whether they are tech literate or not. So once again, people process technology. It's really important to ensure that we are giving them data in a way that is consumable and they can use for action. The reason why this has school district down here, you may question that, right? Why do you have by school districts? Because that's what parents want. Parents want to look at their school district and they want to know what's going on in their school district. So this is updated 2 to 3 times a week with data that's coming in from the state. This is some other data that we use. Obviously, this isn't really technology, but it's more the use of data and a database to look at COVID infections in school children. We've been talking a lot about schools lately, which is why I pulled out the school data. It seems to be of interest to people. And these are data sets that hopefully people can make decisions about. Now, this is a company that I have worked with a lot over the years. These are not my slides. These are from San Mateo, California, but I just wanted to show this to you because this to me is where technology really has an impact because of decision making. And you can see these slides are not only just looking at health data, they're looking at economic indicators. The database behind this is about 100 different data sources that are sourced by the data scientists that work with this group. There's health indicators and there's activity indicators. Now, if you were the Pima County Health Department director, you might not initially, like I did, understand how important economic indicators are. Economic indicators drive the county, and the small businesses want us to know what we're doing. So when we talk about social determinants of health, we talk about employment, we talk about unemployment, we talk about poverty. And so we know economic indicators really matter. So this is just an example of what you can do if you have a good data set behind you and you have data scientists that are supporting you. Here's some more data, once again, from this group where we are working with them in Pima County, and at some point we will have Pima County data to show, but you can look at top destination, where are people going? Now you'll recall early in the pandemic, mobility really mattered, where people went, how quickly they went, were they staying home or not staying home? How do you judge that? You look at how many cars are on the road, you look at where people's phones are. So this kind of pulls this all together. And then the other thing is artificial intelligence. I don't have a lot on that. I think AI is critical to public health. If I could predict for you where I should do a voluntary shelter in place that would decrease the increasing numbers we're seeing in Pima County, I would do it, and I would do it right now. And I would go out to those census tracts and say, hey, you guys really got to work with us. I can't do that. I don't have enough knowledge. I don't have enough information. So what's missing? For those entrepreneurs out there, interoperability. I can't believe we're still talking about interoperability. We are still talking about interoperability, sharing of data, normalization of data, longitudinal and community-based views, the transition to a data-driven culture. That's our commitment at Pima County. We're going to be we're in the process of transitioning to a data-driven culture from a health perspective. And then this engagement of resident scientists. I hate the word citizen scientists, so I've changed it to resident scientists, but all of you guys are scientists. Everybody in your family is a scientist. And the ability to really work closely with them and figure out what they're doing and how they're making a difference would be really helpful. I just wanted to share with you a little bit about what the priority issues are, because I was asked to talk a little bit about where Pima County is going. We're in the process of initiating a strategic plan, but we just finished a very, very large survey with over 22,000 responses. And you can see here the priority issues: behavioral health, substance use, misuse, social determinants, and diabetes. That was related to some data we got. Now, obviously, health equity, anti-racism were also included, and there's a lot more detail. I just wanted to share this one with you. And then what public health issues and innovations from a technology perspective should you consider investing in? And you can see, interestingly enough, this was for the health department. We did this. We didn't do this for the county. And what you see is housing. So how do you address climate change? How do you address affordable housing? What's the technology that we as the health department can use to support these multiple things? And I'm not going to go through this because once again, you'll get these slides. I worked for Indian Health for a really long time. Beading is really important. And my friend Bruce Fink and I used to always do a slide show back and forth about beading the necklace. What did it mean to bead a necklace? And what it really means is bringing people together. So what you see right here, The CDC is actually in Pima County right now. We asked them to come in, and they generously responded and are here to help us do some evaluation of some different things going on in the pandemic. The U.S. Digital Services is the tech group that Todd Park stood up under the Obama. They're the people that did rescued healthcare.gov. But as an aside, I worked on healthcare.gov and before they came, so I didn't need to be rescued, but maybe we did. They're working with us to do some application development. Partners in Health is an NGO well known in low and middle income countries. They're at the county right now helping us figure out that care management platform. Resolve to Save Lives, Tom Frieden's NGO, where with full disclaimer, I did work on that for about 2 years. I worked for him part-time. But Resolve to Save Lives is also doing some really creative stuff in the metrics world and the technology world of what we need to do for disaster response, coronary vascular disease, and emergency preparedness. And then these other people, and so the entrepreneurs, you're always welcome to come visit me, because I think most of you are really exciting and can make a difference in the county. And then the questions we're asking ourselves: what do we do? Are we important? Does public health matter? If we matter, how do we fit in? How do we technologically fit into the healthcare system? Really difficult question. Technology matters. COVID's an example here, but in and of itself, it's just one exemplar. Community matters. I am an old community organizer. I worked for the farm workers a very, very long time ago. If you're a good community organizer, nobody knows you're there. You leave and the community has it together. That's how technology needs to be. Technology needs to be in the background. It is not, for me, the be-all, end-all. The old Schumacher book, Appropriate Technology, that's really what I think we should be doing. It's easy to get enamored with the bright, glittery new technological solution. For those of you who work in the public sector, most of the public sector can't afford those things. So what you do is you figure out ways to work around it, but you get to where you need to get. I used to say when I was a federal employee that I wanted the Office of Management and Budget to let me waste 10% of my money. And the reason is because if you're not doing some cutting edge work, you're never going to get over the precipice. You're not going to be able to jump the void. So you got to be able to do some technology that is a loss leader, and you just remember to learn from it. Humility, cooperative and integrated learning systems. And with that, I will shut up, because that was a whole lot of information really quick.
We already have one question in the chat that I will read out to you real quick. So it was sent to me, and it says, out of your time as the Pima County Health Director, what piece of data has been most invaluable as you face the COVID pandemic?
Testing results. There are many different data sets that I look at every day. The one thing I look at the most that gives me the most fear is the 7-day rolling average of our cases, and that comes from testing results. So I can tell you right now, a week ago, the 19th, our 7-day rolling average was 59. That's 59 cases a day for the past 7 days, blah, blah, blah. So it's a week later. I think maybe it's 8 days later. Our rolling average is now 98. So we went from 58 to 98. That means now we have 98 cases on average a day. It scares the crap out of me. So that's why I say that, because that's the one factor that gives me early insight into whether I'm in trouble or not. And today, because I did that, I reached out throughout the state, throughout other counties. Other people were seeing increases in COVID. We were not. And I think we had just gotten a wind that was protecting us, and now we're going to travel with everyone else. Any other questions, you guys? Right, that was a lot of data really quick.
We have another one in the chat, and it says, can you talk about mobile health that could potentially be used to get timely information any examples of how public health departments are using this technology?
Yeah, so I think it's important to remember that technology should be platform independent. It's not, but mobile is just a platform, right? It's like a tablet, it's like a PC. And the limitations are mobile are the environment. So you can't put as much data on there. You can't scroll, you might not be able to do as much quick analysis because maybe you get 5 data points as opposed to 30 data points that you might have on a large screen. But mobile can be used for everything. And when we look at community-based work needs to be in the community, and that's where mobile has its most benefit. Now, I would also argue that mobile has a huge benefit for the resident scientist as well as the community members. One thing to recall, though, as we talk about equity and inclusion, is not everybody has a mobile phone. So solutions that are geared specifically for mobile phones, like contact tracing on like COVID Watch, preclude people that don't have mobile phones from participating. So it precludes people that are sharing phones or have a flip phone or have a phone that they can only buy minutes for 5 minutes a day. However, the other thing I would say, though, is I did a lot of work the last 4.5 years in sub-Saharan Africa. And if you go to Kenya, mobile banking is it. Everybody is doing mobile banking. They're doing it primarily on an Android platform. But so I think that we in the United States have not pushed the limit of what we can be able to do with mobile. But I would just caution that I do some work with the Center for Democracy and Technology. And one of the things we talk about a lot there is equity and inclusion related to technology. And so you have to put, you have to remember to put a lens of equity on every decision you make for technology.
I believe Emily had a question. Emily, if you want to unmute and ask your question, totally feel free.
Okay. Hi, Dr. Cullen. This is Emily Waldron. I'm going to put myself, you can see me now. Hi. I wanted to ask you about working with, especially the College of Public Health here at the University of Arizona, in terms of collaborating with faculty right now with data and how much collaboration is going on and what you think that could look like in the future in terms of that partnership with other faculty members.
It's a great question. CDC is here right now, and they're here trying to work with the university a little with data. I think there's huge opportunities, and I think there's huge opportunities to work with Bio5 and the data scientists at the university, and I would hope that we can do that more. And Nirav and I actually had some discussions recently about that. The issue of data ownership and institutional review board and what's public health and what isn't public health still seems to be a stumbling block. And actually on a call yesterday, what I said was, this is really important and we need to get it right, because the impact of making decisions that may end up negatively impacting data access, especially in the public health sphere, reverberate. Now, the caveat to that is I worked in Indian country for forever, and I am incredibly sensitive about ownership of data and reuse of data in tribal settings, but also what does it mean for consent for individuals and for communities. So I think, Emily, there's lots of potential. We really would, I wasn't kidding when I said that. And my plan is we're going to be a bioinformatics, public health informatics powerhouse over here. As long as Mr. Huckleberry gives me some money. No, well, I'm only half kidding. But I do think, when we envision what is health 3.0, what is public health 3.0, data, informatics, public health informatics, population health have to be a cornerstone of that work. But in and of itself, it's insufficient, right? I don't want to just do data for data's sake. I'm kind of over that. I did a lot of my life doing that. So,
well, thank you. Thank you.
You're welcome.
Dr. Cullen, Brad Dreyfus here. Thank you very much for your presentation today. And it really heartens me to see the move towards data-driven policy and programs. So thank you. My question for you is regarding our healthcare workforce. We're seeing our healthcare workforce essentially be devastated by COVID itself, the strains, the stigma, not having the bandwidth, obviously increasing the cost of our whole healthcare system, and then potentially leaving our community without adequate access to care. How is the health department engaging with that aspect?
Brad, it's a great question. Right after I got here, I had actually published a health affairs article about PTSD and healthcare workers. I had responded to the Ebola epidemic and lived through a lot of PTSD after being in Sierra Leone for a couple months. So let me talk about public health, and then I'll talk about healthcare overall, because I think this is really a really important unrecognized issue. We recognize it at the health department after people survived the emergency operations center and we moved back here. Not only did people have still all their emergency response work that didn't go away, but now we had to reopen our clinics appropriately. We need to reopen our clinics. So in terms of support, what we did was worked really closely from an integrated care model to try to get people what they needed. We have had discussions. We run the hospital group as well as the school group but the hospital group is with the CEOs for the hospitals in Pima County, and we meet once a week, and we've had discussions with them in terms of how do we ensure not only appropriate interventions, but long-term support for their workforce. And, we did a couple basic things, which are not technology, but we got, the Health and Human Services to send in lots of workforces. I mean, at one point we had 100 extra people in the county because we worked with them, but I don't think anybody has a great solution to this. There are definitely people working on it, and Mark Carroll through Health Connect is doing work, and I've been working with him in terms of how to create learning collaboratives that can provide solace and support for the healthcare system itself. But I think, Brad, this is haunting us right now, and it's an unrecognized epidemic, in my opinion, of what's happening to the workforce. And I think we're going to have serious consequences from it. And as we go into what I believe is going to be another wave here, I would tell you, I bet half the public health workforce would quit if they could quit, because they can't anticipate going through another 4 to 8 weeks. And I know you're in the ER. I'm sure you can't anticipate it either. It's going to be hard.
I will drop you a line. We've got a group working on these exact pieces, and I'd love to figure out how we can better work with the county. It's something
that would be great.
From the front end, so offline.
Yeah.
But thank you very much for your presentation today.
All right. Does anybody else have any other questions before we wrap up today? Oh, I have one in the chat. I will read it to you, Dr. Cullen. It says, what are the implications for college and university health profession education programs? Developing larger capacities and using technology for practitioners? Are there areas of technology training that will be key for health profession students to prepare them for participating in some of the items that you have in your vision?
Yeah, this is a great question. So I actually have clinical informatics boards. So I'm boarded in family medicine, but I have clinical informatics boards, and I'm a fellow of the American College of Medical Informatics. Everybody should get training in informatics. It should be an integral part of what is happening, either from public health informatics, clinical informatics, pharmacy informatics, nursing informatics. Understanding informatics and understanding, how I talked about terminology. Terminology is really boring, but you should be able to speak that language, because that's the language that's going to drive things. So you need to know, as a professional in anywhere in the healthcare arena, in my opinion, you need to have basic conceptual understanding of what does it mean to have a database? What does it mean to have data fields that are normalized? What does it mean to have a standard terminology, and how do you create a new term? What does it mean to have an HL7 message with information going back and forth? And I will tell you, most people in the public health department think I'm talking gobbledygook from what I just said to you. And we actually have set aside some money in the next year to train at least 30 people in basic public health informatics, because it is the vernacular that people will be expected to use. And if you wanna, you don't have to be tech savvy to do that. You don't have to know how to code, but you do need to understand that when you're asking for a data set or you're asking for more information, that you do it in a way that extends the utilization of technology and doesn't put you in a dark hole. You guys may be aware many of the health IT systems, I would argue the one we have at the county, if anybody lets you add a data field, that's fine. But if it's off by itself and it doesn't have a mama or a dad, I know that sounds weird, but we call them parent data fields, you're going to get yourself in real trouble. So I would just encourage people to do that. Full disclosure, I'm on the board of the American Medical Informatics Association, but AMIA, Oregon Health Science Center, is kind of a renowned place in informatics. They do this thing called a 10 by 10 course. They started with AMIA, which is why I want to do that disclaimer, but it's a week, an hour a week for 10 weeks. And at the end of it, at least you would know what I just talked about, and that would be helpful.
That's great. All right, everybody, we're kind of nearing the end of our time, but we do have time for another question if anybody else has one before we wrap up. All right, well, Dr. Cullen, thank you so much for joining us today, and thank you so much for your presentation. For everybody that attended, I will be sending out the slides to you, and this talk will be posted on the University of Arizona Health Sciences YouTube page within the next week or two.
Great.
So thank
and
you.
Sorry I was late. Thank you for your time, you guys. Have a great afternoon. Bye.